Trevor Baker. The first case study I examined was case study 2. This patient has gained 40 to 50 pounds over the past 10 years and was diagnosed with type 2 diabetes, hypertension, and hyperlipidemia. The first question states, what is the metabolic connection between type 2 diabetes and hyperlipidemia? And before we can find the connection between type 2 diabetes and hyperlipidemia, which this patient suffers from, we must first know what each of these conditions are. So type 2 diabetes is a condition where the body doesn't use insulin properly. In other words, the body either does not make enough insulin or has a resistance to insulin. The reason behind insulin resistance in type 2 diabetes is not entirely known, but is thought to be in connection with the insulin signaling pathways, but specifically dysfunctions in the insulin receptor substrate 2, protein kinase B, and the fork head transcription factor FOXO1A. To add, insulin resistance is connected to a diet high in fats, which causes inflammation in the hypothalamus, which results in a resistance to the signaling of insulin. Hyperlipidemia, on the other hand, is the buildup of lipids in the blood. The lipids responsible for this buildup are primarily triglycerides and cholesterol, especially low-density lipoprotein cholesterol, LDLs. Type 2 diabetes and hyperlipidemia go hand in hand in some patients. When insulin resistance occurs, adipose tissue lipolysis is not inhibited and the release of fatty acids into the bloodstream is continued. Insulin is supposed to be responsible for inhibiting hormone-sensitive lipase, which is responsible for forming free fatty acids and glycerol. When the production of these fatty acids is not stopped due to insulin not inhibiting hormone-sensitive lipase and re-esterification continues to occur in the adipose, the free fatty acids accumulate in the blood by binding to albumin, causing hyperlipidemia. The second question states circulating levels of which lipoproteins would be consistent with the diagnosis of hyperlipidemia. So circulating levels of a lipoprotein LDL, low-density lipoprotein, would be consistent with the diagnosis of hyperlipidemia. LDL is responsible for transporting cholesterol throughout the human body, especially to the artery walls to help with cell wall structure. LDL comes about from the secretion of triglycerides and cholesterol from the liver and very low-density lipoproteins, VLDL, which transport these, primarily triglycerides, throughout the body. These then form the intermediate density lipoprotein, IDL, and ultimate LDLs, which contain a high concentration of cholesterol. When there is a diet high in fats, which seems to be this patient's issue, VLDL and LDLs can accumulate in the blood due to the excess number of triglycerides and cholesterol. As this occurs, atherosclerosis can occur because too much LDL cholesterol is building up in the arteries, causing blockage. On the other hand, high-density lipoproteins, HDL, are lower in patients who suffer from hyperlipidemia. HDL has a function in removing excess cholesterol from lipoproteins and tissues. Therefore, high amounts of HDL is good to have in your body because it gets rid of cholesterol and lowers your risk of heart disease and atherosclerosis. However, when HDL is limited, it cannot remove this excess cholesterol and it builds up in the bloodstream due to LDL. So this patient was prescribed metformin to help manage her blood glucose levels. Metformin reduces blood glucose levels by lowering the activity of gluconeogenesis. The drug inhibits glycerol phosphate dehydrogenase in the liver, which reduces the conversion of lactate to glucose, while also reducing gluconeogenesis production. To add, metformin also plays a role in beta oxidation. Metformin activates AMP kinase, leading to an inactivation of acetyl-CoA carboxylase, which is a rate-limiting step in lipogenesis and an important factor in increasing fatty acid oxidation. As a result, lipid synthesis is decreased and beta oxidation is increased, leading to a decrease in circulating lipids. That is the end of case study 2. I will next examine the third case study. So this patient suffers from multiple yellow-colored lesions all over her body. This could be a sign of xanthelasma or localized accumulation of lipid deposits. They also have elevated plasma cholesterol levels at 500 and 80 mg per dl with a ratio of 4.94 for LDL to HDL, meaning there is an accumulation of LDL. This patient does not have any history of diabetes, hypertension, or other chronic illnesses, but the buildup of plasma cholesterol could be to genetic factors such as familial hypercholesterolemia. A person who suffers from this condition has high levels of LDL cholesterol due to dysfunctional LDL receptors. LDL receptors, or LDLR, are responsible for essentially keeping the cholesterol in the blood at a normal level. Many of these receptors are found in the liver and take up extra cholesterol to dispose of. However, when these receptors become dysfunctional, LDL can accumulate in the blood. They become dysfunctional through a mutation in the LDLR gene, or apolipoprotein B, which allows LDL to attach to receptors of certain cells. This condition can be passed down recessively and is the probable cause of this patient's elevated LDL cholesterol. In many instances where a patient has high cholesterol, especially high LDL, they also have high triglycerides. The high triglycerides occur from the excess VLDL that hold a high number of triglycerides. The high cholesterol occurs from the accumulation of LDL, which is formed from the high number of VLDLs and holds majority cholesterol. This usually is due to hyperlipidemia, or the buildup of lipids in the blood. Hyperlipidemia is usually caused by obesity and a high-fat diet. Nonetheless, for this patient, this does not seem to be the case. Their LDL cholesterol is elevated, but their VLDL and triglycerides are in normal range. This makes me even more confident in saying that this patient is suffering from familial hypercholesterolemia. Hypercholesterolemia is a form of hyperlipidemia, but does not affect the triglyceride concentration in the blood because only the LDL receptors are dysfunctional, as stated above. As a result, VLDL can transport triglycerides to tissues with no issue or accumulation. The LDLs, on the other hand, are not able to dump their cholesterol into the liver, ultimately leading to a buildup of LDL in the blood. This condition can be treated through the use of drugs, such as statins, which reduces cholesterol synthesis, ezetimibe, which reduces cholesterol absorption, and PCSK9, which helps the liver absorb more cholesterol. And that is the end of my case study. Thank you.